Hello, this is Dr. Stanley Kim again. Currently, I'm working at Guam Regional Medical City in Guam. It's very nice to work in a tropical island during the winter time. Today, we will discuss cholangiocarcinoma and the gallbladder cancer. Cholangiocarcinoma is a cancer of a bile duct, and the incidence is not that high, but recently, the incidence of intrahepatic cholangiocarcinoma is rising rather rapidly. Until recently, we had a very limited options in treatment, and the prognosis was not that good. But for the past 2-3 years, tremendous progress was made in the diagnosis and the treatment of biliary cancer. It's mostly due to advancements of technology in molecular science and the development of new targeted therapy and immunotherapy. Let's discuss more in detail, and thank you for watching. Cholangiocarcinoma arises from bile ducts, and the gallbladder cancer from gallbladder and the cystic duct. The cystic duct cancer is classified as gallbladder cancer. They are mostly adenocarcinoma, and the squamous cell carcinoma is less common, but the treatments are the same. Cholangiocarcinoma is more common in men, and the gallbladder cancer predominates in women. The incidence is about 1 to 2 cases per 100,000 in the US each, but they are much more common in Asians, Native Americans, and the South Americans. Usually occurs in age group 50 to 70, but the age of onset is much younger when the cancer arises from primary sclerosing cholangitis or colorectal cyst. The risk factors of cholangiocarcinoma include primary sclerosing cholangitis, very important. Others are colorectal cyst, hepatolithiasis, the gallstone disease in the hepatic bile ducts, alcohol and smoking, hepatitis C, liver cirrhosis, genetic predisposition syndrome such as Lynch syndrome, hereditary hemochromatosis, cystic fibrosis, and liver flukes commonly seen in Southeast Asia, HIV infection, diabetes and obesity, oral contraceptives. The DPP-4 inhibitors are a controversial issue. The example of DPP-4 inhibitor is Januvia, used for diabetes treatment. Among gallbladder cancer risk factors, gallstone is the most important. It's seen in 80% of gallbladder cancer, but gallbladder cancer occurs in very minute group of patients with the gallstone. So not all patients with the gallstone require cholecystectomy. But the porcelain gallbladder is different. It's a calcified gallbladder walls. About 2 to 3% of porcelain gallbladder develops gallbladder cancer, so they need to have cholecystectomy. Large gallbladder polyps is strongly associated. When the size of polyp is 1 centimeter or larger, they require cholecystectomy because of 20 to 30% of them harbor gallbladder cancer. Other factors are primary sclerosing cholangitis, chronic asymptomatic carrier of salmonella infection of gallbladder, anomalous pancreatobiliary junction, diabetes, and obesity. Please look at this picture, the anatomy of biliary system. Biles are produced in the liver, drained through the bile duct, eventually into the duodenum to mix the food to digest them. Like a small brooks, creeks become streams, and the river eventually, the biles are drained through the intrahepatic ducts and then become right and the left hepatic ducts. When they united, become a common hepatic ducts. After cystic duct is added, it becomes a common bile duct. Cholangiocarcinoma is classified by their locations into intrahepatic and extrahepatic cholangiocarcinoma. Please look at this picture. The cancer in the intrahepatic bile ducts are intrahepatic cholangiocarcinoma. Outside the liver are extrahepatic cholangiocarcinoma, which are subclassified into perihilar cholangiocarcinoma and the distal cholangiocarcinoma. The perihilar cancer in the hepatic duct and the distal in the common bile duct. And the Klatskin tumor means that cancer arises at the confluence of right and the left hepatic duct. Bismuth-Corlette classification is for perihilar cholangiocarcinoma, which is the most common types of cholangiocarcinoma, although the incidence of intrahepatic cholangiocarcinoma is rising. There are 4 types. Type 1, cancer in the common hepatic duct. Type 2, it involves the confluence of right and the left hepatic duct. Type 3 involves either right or left hepatic duct. Type 4, both hepatic ducts or multiple locations. Depending on the location of cholangiocarcinoma, the clinical manifestations are different. For example, patients with the intrahepatic cholangiocarcinoma, they develop abdominal pain, weight loss, less commonly jaundice, because it doesn't involve the biliary duct that much as extrahepatic cholangiocarcinoma. Their symptoms are mostly biliary obstruction, jaundice, itching, dark urine, etc. As disease progresses, abdominal pain, and the weight loss and fatigue. When cholangitis develops, patients can have fever, pain, and sweating. But gallbladder cancer is different. Mostly they don't have any symptoms. So most cases are diagnosed during or after cholecystectomy, done for gallstone or acute cholecystitis or chronic cholecystitis. About 10% are diagnosed before surgery. So the symptoms and the signs are mostly gallstone or cholecystectomy, abdominal pain, nausea, vomiting, and anorexia. When the tumor invades the bile duct, then they develop obstructive jaundice. Coover-SEER sign, the palpable gallbladder in the jaundice patients, was originally considered as a sign of gallbladder cancer or pancreatic cancer, but now we know that it can be seen in benign conditions such as chronic pancreatitis or colorectal cyst. Mirici syndrome is the symptom complex of compression of common hepatic duct by an impacted stone in the gallbladder neck. They develop pain, jaundice, fever if cholangitis develops. It can be the symptoms of gallbladder cancer. Imaging studies are very important for hepatobiliary malignancy diagnosis and management. That include ultrasound, multiphasic multidetectoral CT scan, MDCT, MRI and MRCP, ERCP, endoscopy ultrasound, percutaneous transhepatic cholangiography, intraductal ultrasound, and for metastatic workup, CT scan of the chest and the PET CT scan. Transabdominal ultrasound detects both intra and extra hepatobiliary duct dilatation, and also it visualizes the gallstone, gallbladder polyps very well. Large polyps bigger than 1 centimeter or larger, and the wall thickening without cholecystitis are suspicious signs of gallbladder cancer. Gallbladder cancers are found in 23% of large gallbladder polyps, 1 centimeter or larger. This is the perihilar cholangiocarcinoma seen in the ultrasound. The same cancer is seen in the CT scan as a thickened, enhancing bile duct. This is ultrasound image of gallbladder cancer inside the gallbladder. Multiphasic multidetectoral CT, MDCT, and the MRIs are very useful for proximal cholangiocarcinoma, detecting intrahepatic tumor, and also good for extrahepatic cholangiocarcinoma by locating the level of biliary obstruction. Please look at this multidetectoral CT scan of the intrahepatic cholangiocarcinoma. The same tumor is much better visualized in the gadocetic acid enhanced MRI. Perihilar cholangiocarcinoma invading the liver parenchyma. MDCT is good in assessing vascular invasion and its resectability, but not as good as for lymph node involvement. And also patients with a primary sclerosing cholangitis can have lymphadenopathy, so sometimes lymph node biopsy is necessary to distinguish metastatic lymph node from reactive lymph nodes. MRCP, look at this picture, the MRCP. Visualize the proximal and the distal bile ducts. It's non-invasive because we don't use contrast. Interestingly, the biles function as a contrast in this case. It's very good in assessment of tumor extent, and also MRCP accurately detects the common bile duct stone, helpful to distinguish it from tumor. But I'd like to mention that this MRCP should be done before ERCP or other biliary decompression, because when the bile is full in the biliary ducts causing dilatation, the image is much more clear. ERCP is more invasive. You can use the to get the cytology and the biopsy. And also we can place the stent or even sphincterotomy to release the obstruction. The stent has two kinds, metal stent like this picture or plastic stent. The metal stent has a longer patent rate, 6 to 12 months, but cannot be removable because tumor or tissues can grow over this stent. Plastic stent is replaceable, removable, but the patent rate is very short, 3 to 4 or 5 months. This ERCP can cause complications, pancreatitis, cholangitis, bleeding, perforation, and even death in 1% or less. Before surgical resection, many patients already had ERCP or percutaneous transhepatic cholangiography to decompress the biliary obstruction, but usually not recommended unless patients have a very high bilirubin level over 10 milligram per ml, or surgery is delayed, or for example, patients undergo neoadjuvant chemotherapy. Then you can decompress the biliary obstruction before surgery. When ERCP cannot decompress the biliary obstruction, we use percutaneous transhepatic cholangiography, PCT, and the biliary drainage. Please look at this picture. By looking at the ultrasound images, the interventional radiologist introduced the needle through the skin and the liver into the dilated bile duct. And then you drain this bile through the catheter into the external bag. We inject the contrast. You can see the cholangiography. It may cause seeding of cancer cells in the draining tract. So before surgery, you need to discuss with the surgeon if it's okay or not. Endoscopic ultrasound is very useful in accurately assess the tumor penetration, depth of invasion, lymph node status, extra biliary organ involvement, and also you can have fine needle aspiration biopsy or can obtain the bile specimen for cytology. The intraductal ultrasound is one step further. You introduce the small cannula into the common bile duct or even pancreatic duct to take images of ultrasound. Of course, you can obtain the bile specimen for the cytology and the fine needle aspiration at the same time. Now let's discuss tumor markers. CA19-9 CEA, alpha fetoprotein for hepatocellular carcinoma, IgG4. CA19-9 is elevated in about 80% of cholangiocarcinoma with a normal value less than 37 units per ml. It also elevated in gallbladder cancer, pancreatic cancer, and the benign conditions such as primary sclerosing cholangitis, pancreatitis, biliary obstruction, nonspecific cholangitis, and even in renal failure. Because patients with a primary sclerosing cholangitis, a little bit high CA19-9 doesn't necessarily means patients have a cholangiocarcinoma. So when you suspect that, the cutoff level has to be much higher, higher than 129 unit per ml. Lewis blood group negative patients have a false negative CA19-9 because even they have a cancer, because Lewis antigen is needed to produce CA19-9, they have zero CA19-9. About 5 to 10% of general population have a Lewis blood group negative. Very high level of CA19-9, more than 1,000 units, indicate unresectable advanced disease, especially peritoneal metastasis. And the CEA is a well-known non-specific tumor marker and is elevated in 60 to 70% of cholangiocarcinoma. So when both CA19-9 and the CA are high, then it's very good in suspicious in diagnosis of cholangiocarcinoma. Alpha-fetoprotein, as we know, is elevated in hepatocellular carcinoma and the mixed hepatocellular cholangiocarcinoma, not in pure cholangiocarcinoma. IgG4 is a marker for autoimmune cholangitis, such as primary sclerosing cholangitis. But it also may be elevated in cholangiocarcinoma, so it cannot use to distinguish primary sclerosing cholangitis from cholangiocarcinoma. In summary, when the alpha-fetoprotein is negative, but CA19-9 is positive, and then you suspect cholangiocarcinoma, primary sclerosing cholangitis. When alpha-fetoprotein is positive and the CA19-9, then of course hepatocellular carcinoma. When the alpha-fetoprotein is positive and the CA19-9 is also positive, then you suspect a mixed hepatocellular carcinoma, cholangiocarcinoma. And the CEA is a positive, very frequently positive metastatic cancer, like from colorectal cancer, and in about 60% of cholangiocarcinoma or 20% of hepatocellular carcinoma have a positive CA levels. When both CA19-9 and the CA are positive, then of course we suspect the cholangiocarcinoma as well as gallbladder cancer and the biliary pancreatic cancer. When you suspect cholangiocarcinoma, like when you find the biliary dilatation or intrahepatic lesion in ultrasound or CT scan, then we do a good history and physical lab test, the CMP, CA19-9, and the CEA. Alpha-fetoprotein only for intrahepatic lesion to distinguish it from hepatocellular carcinoma. And we know a biliary obstruction increased the direct conjugated bilirubin. Diagnosis of proximal lesions like a intrahepatic cholangiocarcinoma, we use MRI, MRCP, or MTCT. For tissue diagnosis, CT-guided or MRI-guided biopsy can be used. Percutaneous transhepatic cholangiography and the bile aspiration for cytology may lead to a tissue diagnosis. For distal cholangiocarcinoma, in addition to the ERCP, to obtain the brushing cytology or tissue biopsy, endoscopy, ultrasound, and the fine needle aspiration is very useful and much more sensitive than ERCP in making tissue diagnosis. To rule out metastatic disease, CT scan of the chest is always included as initial staging workup, but not the PET-CT. It's no advantage for staging of primary tumor over MD-CT or MRI, MRCP. So it's not routinely included in initial staging workup unless you suspect the metastatic disease, especially before diagnostic laparoscopy or surgical resection. And those proximal or distal lesions are kind of easier than Perihilar cholangiocarcinoma in terms of tissue diagnosis. With the biospecimen, you can request a FISH test to detect abnormal chromosome, which may increase the sensitivity. But tissue diagnosis may not be necessary for certain cases. Patients who definitely have a resectable disease with a characteristic finding of cholangiocarcinoma in imaging studies, or patients who just requires palliative care like a biliary drainage. As we know, most patients of gallbladder cancers are diagnosed during or after cholecystectomy. So still patients need to have a CA19-9 CEA, and the imaging studies include ultrasound, CT, MRI, MRCP. Endoscopic ultrasound, PET CT scan has limitation due to high false positive rate with a coexisting inflammation like a cholangitis, cholecystitis. Large gallbladder polyp has a high risk of harboring gallbladder cancer. Porcelain gallbladder, as you see, the calcified gallbladder wall, they need to have a cholecystectomy. The staging of cholangiocarcinoma is very complicated. Depending on the location, the TNM systems are different. I draw these pictures for better understanding. For intrahepatic cholangiocarcinoma, TNM staging, the T1 means solitary tumor. If it's less than, if 5 centimeter or smaller, it's a T1A. Bigger than 5 centimeter, T1B. Multiple tumors or tumor invading vascular system are T2 lesions. T3 tumors perforates visceral peritoneum. T4 invades the extrahepatic organs. Any regional lymph node metastasis N1. So stage 1 means T1 tumor without lymph node metastasis. Stage 2, T2 N0. Stage 3A, T3 N0. Stage 3B is a T4 N0. But stage 3C means any size of tumor with the lymph node metastasis. Stage 4 means distant metastasis. Perihilar cholangiocarcinoma has a different parameter. T1 tumor confines to the bile duct, T2 beyond the bile duct, T3 invades the portal vein, hepatic artery branches, T4 invades the main portal vein or bilateral portal vein branches. With a 3 or less lymph node metastasis is classified as N1, N2, 4 or more lymph node metastasis. T1 means stage 1 means T1 N0, stage 2 T2 N0, stage 3 either T3, 4 without lymph node metastasis or N1 disease regardless of the tumor size, which is stage 3C. Distant metastasis stage 4. For distal cholangiocarcinoma, it's also different. T1 tumor means the tumor invades the bile duct wall less than 5 millimeter in depth. T2 5 to 12 millimeter, T3 more than 12 millimeter, T4 invading celiac axis, superior mesenteric artery or common hepatic artery. N1 and N2 and the stage. This staging is kind of much more lenient because they have a better prognosis. For example, even N1 disease is still stage 1, stage 2, and the N3 and stage 3A means N2 disease, and even with the T4 N2, it's still stage 3B. It reflects the better prognosis The T-staging of gallbladder cancer depending on the depth of penetration into the gallbladder wall. T1 divides into T1A and T1B. T1A means tumor invades the lamina propria, and the T1B into the muscular layer. And the T2A means the tumor invades the perimuscular connective tissue, and on the side of the liver is a T2B. And the T3 means tumor penetrates the gallbladder wall completely, invading one adjacent organ, such as duodenum. When it invades the liver, it's a T3 also. T4 diseases are much bigger, deeply penetrates to the portal vein, hepatic artery, biliary duct, and the two or more adjacent organs. I again emphasize that T1A means tumor invades the up to lamina propria, and the T1B up to muscular layer. And if the regional lymph nodes metastasis is N1 or 2, depending on the number, 1 to 3 is 1, 4 or more, and 2 disease. And the stage 1 means small tumor without lymph node metastasis. Stage 2 to T2, stage 3, T3, and then if the N1 disease is stage 3B, and when it's N2 disease is stage 4B, and also distant metastasis is stage 4B. Because surgical resection is the only curable treatment, it's very important to evaluate patients for surgical resection and the resectability. Resectability with negative surgical margin in cholangiocarcinoma is much higher in distal cholangiocarcinoma than intrahepatic or perihilar cholangiocarcinoma, have a better prognosis. The contraindications include, of course, metastatic disease or invasion to the major vascular system or local invasion into extrahepatic organs. But depending on the surgeon's skill, portal vein reconstruction or resection of extrahepatic lesion may be done. Routine pre-op biliary decompression is not recommended. We discussed in the previous slide. Unless patient have a very high bilirubin level over 10, then wait until bilirubin level drops below 3 before surgery. Gallbladder cancer resectability is similar. The contraindication, of course, metastasis to the liver or peritoneum, such as malignant ascites, or distant lymph nodes like a para-aortic, paracabal, celiac artery lymph nodes. Extensive involvement of hepatoduodenal ligaments, which contain common bile duct, hepatic artery, and portal vein. Encasement of common bile duct, the hepatic artery or main portal veins. Direct involvement of colon, duodenum, or liver is not absolute contraindication because depending on the surgeon's skill can be resected. If patients have a jaundice, if the location of gallbladder cancer is in the fundus, it's a relative contraindication, but not in the gallbladder cancer of infundibulum or cystic duct cancer. Diagnostic laparoscopy is often recommended before surgical resection to ensure no metastatic disease. The surgical resection of intrahepatic cholangiocarcinoma involves hepatic resection and the extrahepatic bile duct resection and the portal lymphadenectomy, unless the tumor locates in the peripheral area. Then hepatic resection without lymphadenectomy or extrahepatic bile duct resection is sufficient. 5-year survival is 40 to 60%. Perihilar cholangiocarcinoma requires more extensive surgery. For type 1 and B, 1 and 2, en bloc resection of extrahepatic bile ducts and the resection of the gallbladder regional lymphadenectomy with or without caudate hepatic lobectomy, followed by Roux-en-Y hepaticojejunostomy. And the type 3 tumors is even more extensive, require more extensive hepatic lobectomy or trisectionectomy. Type 4 is often unresectable, but resection is possible depending on the surgeon's skill. And the resectable disease 5-year survival 40 to 50%. For distal cholangiocarcinoma requires Whipple procedure, pilorous preserving surgery is preferred. 5-year survival 50 to 60%. Gallbladder cancer is a little bit different because we know most of gallbladder cancer found during or after cholecystectomy. When the cancer is found during cholecystectomy, the surgery is avoided and referred to an experienced surgeon unless the original surgeon is a hepatobiliary surgeon. If found after cholecystectomy was done, then referred to an expert surgeon for re-resection, of course after staging workup with the imaging studies. For T1A means the tumor invades up to lamina propria. Simple cholecystectomy is sufficient, but beyond that, patients requires extended cholecystectomy, which include cholecystectomy plus adjacent liver tissue resection, regional lymphadenectomy. T2 region also extended cholecystectomy. Wedge resection is as good as segmentectomy. T4 is even more. They need to have resection of involved extra hepatic organs such as colon, duodenum. So they have a high re-resection rate because of increased local recurrence. The complications, bilic, bleeding, infection, some mortality there. And the prognosis of resectable gallbladder cancer is better than cholangiocarcinoma, 65% of 5-year survival rate. Adjuvant therapy is usually given after resection. When the patients have positive margin or positive lymph nodes, then concurrent chemoradiation therapy or chemotherapy followed by concurrent chemoradiation therapies are given using 5-FU or capecitabine. When you use the systemic chemotherapy after concurrent chemoradiation therapy, gemcitabine with or without capecitabines are used. American Society of Clinical Oncology recommends capecitabine alone for all resected cholangiocarcinoma for 6 months. But if they have a positive surgical margin or gallbladder cancer, chemoradiation therapy is recommended. NCCN guidelines are a little bit different, more lenient. For extrahepatic cholangiocarcinoma with negative margin, negative lymph node metastasis, observation is an option, along with 5-FU chemo or chemoradiation therapy. But when the margin is positive, positive lymph nodes, then 5-FU chemotherapy alone or chemoradiation therapy or combination of both are recommended. Intrahepatic cholangiocarcinoma, the same thing. Observation for negative margin, negative lymph nodes, or the chemotherapy, chemoradiation, or combination for margin positive or positive lymph node disease. Gallbladder cancer has a high distant metastasis rate. So single capecitabine for 6 months to all patients is recommended according to ESCO, but NCCN guidelines exclude the stage 1A disease, which means tumor invades the lamina propria only. Neoadjuvant therapy is not our standard treatment, but locally advanced non-resectable intrahepatic cholangiocarcinoma was downstaged to resectable disease with a radioembolization and the chemotherapy. Liver transplantation is not a standard therapy for cholangiocarcinoma also due to lack of studies proving its benefit. But resectable cholangiocarcinoma with a primary sclerosing cholangitis or a non-resectable small hilar cholangiocarcinoma may be referred to transplant center for consideration. After resection, patients are followed up every 3 months for 2 years with the CBCC-MP CA19-9 and the CEA, and thereafter every 6 months. Imaging studies are as needed. For locally advanced unresectable disease, we used to use cisplatin and the gemcitabine as a gold standard with a not so good outcome. Until 4 or 5 months ago when FDA approved durvalumab, the immunotherapy drugs used in combination with cisplatin and gemcitabine, because this combination improved the overall survival over 12 months. In addition to this systemic therapy, we have many options. For intrahepatic cholangiocarcinoma, concurrent chemoradiation therapy has a better local control when used with the high-dose radiation. Yttrium-90 radioembolization concurrently with the cisplatin and gemcitabine showed the very impressive results, median overall survival about 2 years. And the local ablation with radiofrequency microwave ablations can be used. Stereotactic body radiotherapy has a better overall survival than chemoradiation therapy or radioembolization, and the proton beam therapy can be used. For extrahepatic cholangiocarcinoma, we don't use high-dose radiation therapy or stereotactic body radiotherapy because they can hit the small bowel, causing severe small bowel toxicity. So we use the concurrent chemoradiation therapy with 5-FU and gemcitabine. After the treatment, patients need to be reassessed for resectability because resection is the best hope for cure. Liver transplantation is not a standard, as we discussed, but can be considered case by case. And the gallbladder cancer follow those principles of treatment of cholangiocarcinoma. I like to mention that gemcitabine is given after biliary decompression when the patients are deeply jaundiced because of its liver toxicity. Hyperbilirubinemia increases risk of cholangitis. And also targeted therapy and the immunotherapy can be used the same as treatment of metastatic disease, which will be described next slides. For metastatic disease, like a locally advanced tumor, the combination of durvalumab, cisplatin, and gemcitabine is the choice. Patients still can have just chemotherapy with cisplatin, gemcitabine with oxaliplatin. When patients have a jaundice, you can't use gemcitabine because of liver toxicity, then use K-Pox or Folfox. For frail patients, single capecitabine or gemcitabine is sufficient. When disease progressed over the first-line therapy, Folfox is the choice preferred second-line chemotherapy. But nowadays, we have a target therapy and the immunotherapy, which provides less toxicity with a better efficacy. Most importantly, FGFR2 fusion rearrangement positive tumors. FGFR2 stands for fibroblast growth factor receptor 2. There are 3 inhibitors: pemigatinib, infigratinib, and futibatinib. Especially this futibatinib is very recently approved by FDA about 6-7 months ago. Overall response rate 42% and duration of response 9.5 months. Specifically, you need to check phosphate level because it can cause hyperphosphatemia. It also can cause alopecia. When the tumor is negative for FGFR2 fusion or gene rearrangement, there are still many biomarkers to look for. Deficient MMR MSIH or high tumor mutational burden. You use pembrolizumab. Pretty impressive response rate. For TRK fusion rearrangement, larotrectinib with the overall response rate is 75%, and trectinib is also another choice. For BRAF V600E positive tumors, we use dabrafenib with the trametinib. Overall response rate is almost 50%, very recently approved. For IDH mutation, we have ivosidenib for IDH1 inhibitor. RET fusion tumors, selpercatinib. For HER2 positive tumors, Herceptin with the Perjeta. EGFR positive, we have inhibitor Tarceva with or without bevacizumab. When the tumor has a PD-L1 positive, nivolumab is choice over Keytruda, pembrolizumab, because pembrolizumab, it's the overall response rate is just about single digit. The nivolumab provides the disease control rate is about 50%. If PD-L1 negative, you still can use dual immunotherapy with nivolumab and the ipilimumab. If nothing's positive, we still have a option, ramucirumab, Cyramza, which is vascular endothelial growth factor receptor 2 inhibitors. According to the old SEER database, the 5-year survival rates of cholangiocarcinoma are not that good. Intrahepatic localized disease 25%, extrahepatic even worse 17%, although gallbladder cancer has a much better survival rate. But when disease metastasizes to distant organs, the 5-year survival rate is decimal, 2%, 2%, 2% across the border. However, more recent data show better prognosis. For example, intrahepatic cholangiocarcinoma after margin negative resection, 5-year survival is 63%. Even for metastatic disease, with a newer drug combination, durvalumab with the cisplatin and gemcitabine, the 2-year survival is over 25%. Please look at the survival curve of cholangiocarcinoma patients who received the durvalumab, cisplatin, and gemcitabine. This is a red line. After about 2 years, the line becomes plateau, indicating patients who lived up till like 2 years, they continue to live. But those patients who received the cisplatin and gemcitabine without durvalumab, the graph just falls. I took this photo several days ago in Guam. Beautiful rainbow over the ocean. I thought about Bible verse, the God's peace. Peace I live with you. My peace I give you, I do not give to you as the world gives. Do not let your hearts be troubled, and do not be afraid. John 14:27. I hope all cancer patients have a courage and a peace from God. Thank you for watching.